Spinal deformity includes both scoliosis, that's side-to-side curvature, as well as abnormalities in kyphosis and lordosis. That would be the slouching of kyphosis, or lordosis would be a swayback, or increased lordosis, it's called. So those are the actual deformities. It can be positional or just postural, like most teenage kids kind of tend to slouch a lot. It can be structural, though, where side-to-side is not a natural slouch position. The kids are actually checked for that on various well-child checks. They do the bend-over exam. You may have remembered those during gym. They're not doing as much in gym now, but they certainly are doing it in the pediatricians and family care offices. If there is a problem, then we try to get an x-ray or referral to try to figure out what the problem is. It's about 1 in 1,000 for a frank scoliosis that needs treatment. Not so often does it actually get to the point of needing surgery. That's very rare. Bracing, however, is a little bit more common, perhaps about 10 times as much as you need for surgery. And many times, I would say the majority of patients are just followed to make sure their scoliosis doesn't increase to above 25 or 30 degrees, in which case we do instill bracing. If they can stay a low number of degrees, then we just leave them alone. We just check them every 4 to 6 months and make sure it doesn't develop during their growth years. Most of the time, it's called adolescent idiopathic scoliosis. That's 90% of the cases of scoliosis. Unknown cause, that's what idiopathic means. Adolescent means it comes on after the age of 10, and scoliosis is curve over 10 degrees. So we don't really know what causes it still. A lot of research, but nobody's really ever been able to define why it occurs. It all depends on whether or not we treat it is depending on the child's age. If a child's still growing, that's when we're really watching. We want to make sure that instead of getting, we want to make sure that as they grow, that they don't get more crooked rather than tall. So if some of their height is going towards curve generation, we try to treat that with a brace. And that's until they're fully grown. So most girls stop growing at around age 14 or so, most boys around 16. So it's in that 2 or 3 year period leading up to that cessation of growth, again, those ages, 14 and 16 for girls and boys, that we would do a brace. Sometimes these braces are well tolerated. It all depends on the individual who says he'll wear it 16 or she'll wear it 16 hours a day, sometimes less than that, sometimes more, to try to channel their growth into getting taller, not more crooked or more scoliotic. If the brace doesn't work, then sometimes surgical intervention is important to do safely with rods and screws holding this spine straight, and that can eliminate the progression in the adult years. The most challenging operation I do, and I think the one that I do very safely, it does include exposing the back, the spine that part of the spine that we're going to fuse, and then putting in the hardware in a very safe fashion. Now, once it's in, we have a lot of tests to make sure, intraoperative CAT scans and spinal cord monitoring to make sure that the hardware is in the right place. We then steer and adjust the screws so that they straighten the spine as much as safely can be done. And then we put bone graft in on the side so that you wind up with a very solid construct that doesn't move anymore, but also prevents the scoliosis from worsening, especially as an adult. So it's a surgery that's much safer now than it ever used to be, much better than it ever used to be. Back in the days, you remember, you may have heard people that have been in a cast for a year of their life, way back when it was first being fashioned and pioneered. Now the techniques, the hardware is better, the techniques are better, the kids are in the hospital only for 3 to 4 days, up to a week, where it used to be weeks and months in the hospital.